And last is Ms. Beckett.
Well, thank you, Mr. Chairman and members of the subcommittee. My name is Julie Beckett, and I am the Policy Director for Family Voices, a national grassroots organization of families and friends speaking on behalf of children with special health care needs and their families. But in particular, I'm Katie Beckett's mother. And as you know, Katie was the first home and community-based waiver child in 1981. She sits behind me today and about to turn 30 years old, scaring me to death. And the important part of this is that we've been fighting for this for almost these full 30 years. And what I would like to see is something actually done about providing home community-based care for individuals with disabilities. Family Voices families include a number of individuals who are transitioning to the adult system of care and who are anxiously awaiting a life filled with work and play and active participation in their communities. You see, when given the types of services needed, many of these children and youth can live long and prosperous lives, but access to important programs such as early periodic screening, diagnosis, and treatment, EPSDT, and special education are critical, especially at an early age. Life and death decisions depend on access to the necessary services required by this very vulnerable population. EPSDT provides the best benefit package for our children and youth with special health care needs. Frequently, it is necessary to access Medicaid even if a child or youth has access to private health insurance. Private insurance is increasingly unwilling to provide access to the types of care that these children and youth need. It is only the protection of EPSDT and the mandate to cover all medically necessary services that guarantees our children access to these necessary services. The federal Medicaid program has taken steps to limit access to this vulnerable population by proposing dangerous regulations that could limit the important therapies needed to sustain mobility and important physical and mental and life-sustaining therapies that allow these children and youth to grow in their communities and participate actively. These therapies and treatments offer the hope of a better future. It also allows children and youth with special health care needs and their families to participate more fully in the life of their communities. These services allow us all to experience children and youth with special health care needs and all they are capable of, so that we as a society define them not by the limitations, but by their capacity for success despite their mental and physical limitations. And you'll note there are several stories that I've attached to my testimony. The one about Shane Hafley should demonstrate the importance of these services. The Maternal and Child Health Bureau has just released the latest statistics from the National Child Health Survey, which is a random telephone interview with households across the United States. This survey demonstrates that increasingly these children rely on public health insurance because there has been no public outcry in response to the denial of medically necessary services. There also has been no law passed that mandates that when a physician orders treatment or services that are medically necessary, that those services should be paid for by private insurance. The Maternal and Child Health Bureau's goal to achieve a medical home for every child has eased some of these concerns as it cuts down on emergency room care because they now have a consistent source of care and the services are better organized. In fact, the Medicaid Commission that I was honored to serve on made a recommendation that all individuals covered by Medicaid receive their care from a regular source of care as used in the Maternal and Child Health Bureau's medical home model. This goal of achieving a medical home for every child must not be attached to complicated payment structures like those used in managed care. Payment incentives can have a negative impact and can limit care that should be provided. Again, this demonstrates, as shown in the Maternal and Child Health Bureau's national survey, children and youth do best when they are part of a medical home and the cost of care either stays the same or decreases as families are financially able to provide for the extensive care needs of their child or youth. This, too, can apply to adult care. When targeted case management helps access the right kinds of services necessary for an individual to stay in their communities and actively participate in work. The Family Opportunity Act that was built on the Ticket to Work and work incentives legislation provides for families and individuals with disabilities to access a Medicaid buy-in program so that these families and individuals are employable when a company does not have to use all of their health benefits to pay for services that these workers may need. I am proud of the fact that my daughter Katie served on the advisory panel for several years and actively participated in the Beneficiary Summit that identified the barriers young people with disabilities face when forced to remain on Social Security programs that present barriers to their work participation. The Medicaid buy-in programs give them hope that someday they may not have to rely on these outdated programs that restrict what individuals can do. The Community Care Act approaches many of these concerns, but families need options. Improvements in Medicaid delivery certainly would provide them with some choice in helping their children and young adults survive and prosper. It is agreed that it would be much more beneficial to efficiently and effectively manage a benefits program that helps our children and youth survive rather than relying solely on a cash payment subsidy and restrictions that limit their options. I hope that you will look long and hard at the final report of the Ticket to Work and Work Incentives Advisory Panel, even though this committee does not have jurisdiction, and think about the decisions you make that could impact its success. Finally, removing targeted case management from the list of options makes no sense, nor does restricting school-based incentives that help special education students achieve in schools. And of course, it makes no sense to limit reimbursement for therapies that keep their bodies moving in a direction that keeps them able. Again, EPSDT provides for the most essential medically necessary services, no matter where those services are provided. Limiting the nature of this program to simply cure would certainly fly in the face of congressional intent. I would hope this committee would examine your options to learn more about what these initiatives do and the impact of current proposals on real lives and real families. I have included recommendations for the Subcommittee on Health, and I certainly hope that you will review those. Thank you very much.
Thank you, and we certainly will, and that concludes our opening statements. Now we'll have questions from each of the congressmen and women.